There's going to be a lot of discussion that's going to be occurring today regarding treatment availability, supportive care, management of infections, but everyone really needs to be on the same page about what this disease actually represents, the monitoring of the disease, the response criteria. And so the easiest way to understand this disease is to understand your bone marrow, and the metaphor that I use is the bone marrow as a garden. Your bone marrow is a garden, and that's what we're going to be using to explain this disorder. So if you go to the store, the grocery store, and you buy a soup bone in the store, you'll see the soup bone has two completely separate independent parts. On the outside of the soup bone is that thick rind of bone that makes that bone very strong. And in this metaphor, that bone is the casing of the garden. Then, of course, inside the bone is that kind of brownish, spongy material that you actually use to flavor soup when you make it. It's brown because it's undergone oxidation after the animal's been slaughtered. The freshly slaughtered animal, that central area in the bone is bright red. It's the same color as blood because that's where all your blood is produced, in that spongy area, the marrow inside the bone marrow. And if you look under the microscope at the bone marrow, and everyone here who's a patient has had their bone marrow analyzed under the microscope, you can actually see that the garden of the bone marrow is made up of seeds, plants, and fruit. And each of those represents one of the elements of blood. And if you look at the proportions, the acreage distribution, about 60% of the bone marrow is given over to the production of the white blood cells. The white blood cells are the cells that construct your immune system to help you fight off infections of all types. It's the blood test that your doctors are measuring every week while you're on chemotherapy to make sure those infection-fighting white cells don't get too low. So that's 60% of the acreage. 20% of the acreage are the production of red blood cells. The red blood cells are the cells that carry oxygen to your tissues and feed them, providing the necessary oxygen to combust your calories and burn them to create energy. And the red blood cells that are 20% of the acreage contain little packets of hemoglobin, and hemoglobin is the stuff that we talk about. If you don't have enough, then you're anemic. You have low blood if you have inadequate hemoglobin. That's 20% of the acreage. 10% of the acreage of this garden is given over to the production of blood clotting cells or platelets. So you've got about 90% of the acreage given over to three main crops. But the garden has actually quite a number of boutique crops in it by names that are not important to us today, but it's basophils, eosinophils, mast cells. But the cell that is important to us for the discussion today is a boutique cell that's found in the bone marrow. It represents 1% of the acreage of that garden, only 1%. That cell is referred to as a plasma cell, and the plasma cell has a very specific function, and that function of that plasma cell is production of antibody proteins. That's what it does, makes antibody proteins. And they have memory. So that if you skinned your knee when you were 4 years old, I can assure you that you've got a dedicated plasma cell making antibody proteins to whatever stuff got into the skinned knee. And when you're immunized for your flu shot or your tetanus or your pneumonia, or most importantly, your shingle shot that every single person in this room should have received, you have plasma cells that make antibodies, and those antibodies circulate in your blood as protein and protect you against infection. And that ratio, 60, 20, 10, and 1 plasma cell, that you do a bone marrow in a 1-year-old, that's what the numbers are, 60, 20, 10, 1. You do it in a 30-year-old, it's the same. You do it in a 70-year-old, it's the same. This is a very tightly regulated garden, and the apportionment of the acreage to the various crops is very, very tightly regulated as long as things stay normal. Unfortunately, 6 people per 100,000 per year, about 35 to 40,000 patients a year, that plasma cell, that 1% of the garden acreage, undergoes malignant transformation. And one of the consequences of that malignant transformation is unrestrained and uncontrolled growth. Better, I won't trip now, 1%, and they start to grow. And they start to grow because that's the nature of cancer, unrestrained, uncontrolled growth. And so these plasma cells begin to grow and repopulate the garden. So metaphorically, it's a lot easier to think about these abnormal, unwanted cells replacing the garden as weeds in the garden. It's just an easy way to think about it. And these weeds begin to repopulate the garden. Now, in fact, the diagnosis of multiple myeloma can occur with any percentage of weeds in the garden. You can get problems no matter what the weed percentage is. But for the sake of professionals talking to each other, they've arbitrarily defined, and for certain treatments, eligibility to participate in experimental treatments, we say minimum 10%. So if you have 10% weed acreage, with 1% being normal. If it's 10%, that's called multiple myeloma. The average patient to diagnosis has between 30 and 40% plasma cells, weeds, in their garden at diagnosis. But patients can have 80, 90, 95% replacement of their garden with this weed overgrowth. It's quite interesting with modern therapies that the percentage of weeds in your garden doesn't impact on your prognosis. So how much you have isn't relevant at all. So what are the consequences of having weeds in the garden? Well, the first thing that happens is that these cells begin to replace and choke off the healthy garden growth. You can't grow tomatoes in a garden that is overrun with weeds. The plants won't grow, they'll die. And that actually happens in the bone marrow garden. And the most sensitive crop, the crop that produces the red blood cells. So the increase in the weeds chokes off the red blood cell plants, and so your production, your output of red blood cells from your garden goes down. Your red cell count falls, therefore your hemoglobin falls, therefore we technically refer to that as being anemic, and that's about 40% of patients present, 75% have anemia, 40% present because of their anemia, their low blood, they're run down, they're fatigued, they have no energy, they can't climb a flight of stairs easily. All of a sudden, they just don't have the energy and the pep. And the hemoglobin, which for an adult male is about 15 and for an adult female is about 12, drops, and a diagnosis average is about 9. And just to have some sense, a point of hemoglobin, 1 point of hemoglobin is roughly 1 pint of blood. So that at the time of diagnosis, the average woman is down about 3 pints of blood, and the average man's down about 5 or 6 pints. Thus, the fatigue, the loss of energy. That's actually not the biggest problem with the disease, however. This disease has another problem. These weeds don't remain confined to the garden. These weeds will grow into the garden casing. So when we were talking about the soup bone, we talked about that thick white shell, the bone. The myeloma actually grows right into that white bone. And you know how strong that bone is. I mean, if you took a soup bone that you bought in a store and you could jump up and down on it, you can throw it on the ground, you're not breaking that bone. It is so very strong. But what happens is these weeds actually erode into the surface bone and actually weaken it structurally. And so some of you may have seen your physician and they said, well, there's holes in your bone or black spots in your bone. And the reality is that actually is what's happening as the myeloma begins to erode the healthy calcium and it weakens the bone. And as the bone structurally weakens, a number of things can happen. So usually this occurs for most patients, long bones, ribs, and spine. Now if you think about your spine, basically the vertebral bodies that make up your spine are essentially building blocks. They're little squares, cubes, if you will, one stacked upon another to give you your vertical height. And if these weeds begin to erode into the casing of the garden, they'll drop, they'll weaken, and if you have minimal stress, the vertebral body, the square, will actually collapse and shorten. And since multiple bones typically are involved, since the bone marrow is a fluid organ, the myeloma is kind of circulating everywhere. You know, these blood cancers aren't like breast cancer. We can point to a spot, or colon cancer, we can point to a tumor, or a lung, you can point to a spot. In myeloma and other hematologic malignancies, you can't point to anything. It's just there in your bone marrow and it's freely circulating. So when you have myeloma, it's actually virtually everywhere in your bone marrow. So why do we do the bone marrow here and the pelvic bone here? You'll like this. It's the easiest and least painful. So, but it is everywhere. I mean, if you biopsied here or here, you'd be able to see it in the marrow of the bone. And it's weakening multiple bones, so it's not unusual for patients to present with multiple compression fractures of their spine. And compression fractures of the spine are exquisitely painful. Like any broken bone, the bone won't hurt if you're completely immobilized. If the bone is splinted and it isn't allowed to move, there's no pain. You can't do that with the back. When you have a spinal fracture, compression, sometimes multiple compressions, anything that causes the bone to move will cause lancinating and excruciating pain. So the things, what does the spine do? Well, it can flex like this. Well, you can't get out of bed without bringing your center of gravity forward. So flexion is required. Same thing getting out of a chair. You have to flex forward. It hurts. Getting off the toilet seat hurts. It's very painful. Rotation can be very painful, so patients, again, getting out of bed is a real problem because you can't get out of bed without rolling a little bit, and that causes a little bit of unequal rotation and can cause exquisite pain. The ribs will be affected with this disease as well, and rib fractures are not the least bit unusual, and the trick is that the rib fracture occurred with nothing. Most people get a rib fracture, it's traumatic. Myeloma patients can sneeze and break a rib, slam the car door shut and break a rib, roll over in bed, nothing at all, and a rib breaks. So these are very real problems. Later on, we'll be talking about some of the treatments that are available to help with the remineralization of the bone that has nothing to do with the treatment of the weeds that are causing the problem. So those are the two principal problems related to the cancer cell, the weed, directly involving the marrow. But in a disorder this rare, 1% to 2% of all cancers, an internist in a 30-year career, I would expect, would see maybe 1 or 2 patients with multiple myeloma. So not very common. How do they figure out the diagnosis? How do they arrive at a diagnosis in a patient who's fatigued or anemic or whose back hurts, because back pain is so common in our country, or rib pain? And the key here is remembering what these cells did before they became malignant. What do? They make antibody protein. They make protein. And when they become malignant, they don't stop making protein. That is an ongoing issue. For most, when these cells go from 1% to weeds and growth, they continue to make the protein. And if you don't know what the protein is, this is a bad problem. You need to know about the protein. Now, the protein itself isn't the disease. The protein is something that's made by the disease. The disease are the weeds in the marrow. The protein is a product, but it's not the disease itself. But as the disease evolves and protein is produced, since there's increased numbers of these cells, whether it's 10 or 30 or 40 or 90, the amount of protein that they produce builds up and is detectable in the blood. And so high protein in the blood becomes this incredibly important clue that when an internist sees a high blood protein, they think, gee, there's a high blood protein. And when they do the analysis, they see, well, that's the protein that's made by plasma cells. And if the protein is high, then there must be excessive amounts of plasma cells, weeds. And so I need to get you to a specialist to sample the garden and find out how many weeds there are in the garden to lead to a diagnosis. Now, again, the protein is not the disease. The protein is a marker of the disease, but it's incredibly useful because it's so reproducible. Proteins are measured a lot of different ways. You will have heard M-spike, M-protein, gamma globulin, IgG, IgA, and light chain, kappa and lambda. And every person and caregiver with the disease needs to know what their protein is. I see patients for a second opinion. I go, what's your myeloma protein? They go, I don't know. That's a problem. You really need to know that if you're really to understand what's going on with your disease. So again, it's M-spike, M-protein, GA light chain. And actually, I measure all of those when I see patients because there are different pros and cons about them. So it's useful to kind of have the whole picture to understand. And when you're talking at your support groups, the amount of protein you have is not relevant. If someone's 5,000 and you're 2,000 or 80 versus 20, it doesn't matter. There's no comparing across patients about the amount of protein these weeds make. They make a different amount of protein for everyone. But what's really a big deal, is that protein changes over time. Over time, provide a movie of what's going on with your disease. So although if your protein's 600 and your protein's 30, that's irrelevant. If your 600 protein is 600, 600, 600, 600, it's stable disease. And if it's 600, 500, 400, 300, 200, your disease is getting better because you're killing the weeds that are making the protein. The only way it's going down is destruction of the cancer. And then, of course, if it's going 600, 700, 800, 900, 1,000, that is not good news. That would suggest that the source of the protein, the weeds in the garden, are increasing and making more protein. But keep in mind, the protein's not the disease. The protein's a surrogate marker of the disease, trying to infer what's going on in the garden and what the percentage weeds are. There are alternative ways. You could have a bone marrow every month, and you can have the plasma cells measured directly. Most people aren't big fans. And so we substitute the protein measurement to give us information of what we believe is actually going on with the number of weeds in the garden. So it's the protein. There are some patients, actually, who have the protein discovered incidentally. They were just having a checkup. Protein was high in the blood, feeling great. And then with further investigation, it's demonstrated that this protein is being produced by a population of weeds in the garden that aren't causing any problem with bone damage or anemia. And depending on how many weeds in the garden and how much protein there is, we kind of subdivide this into these pre-myeloma classifications. One of the pre-myeloma classifications is called monoclonal gammopathy of undetermined significance, or MGUS. This is a category where a protein is found, and it's certainly a risk factor that maybe full-blown cancer or multiple myeloma will develop in the future. But if there's been no end organ damage and your blood is good and you're feeling great, these are monitoring. Then there's an intermediate category called smoldering multiple myeloma, where the bone marrow absolutely shows over 10% plasma cells, or the protein is very high, and it is myeloma, but it isn't causing symptoms and it isn't being treated, it's being monitored, which for those of you who watch enough TV realize that goes against what everyone else is telling you, which is always treat cancer aggressively and early. So why are there patients who get diagnosed with multiple myeloma and are told we're going to observe? And the answer is pretty straightforward. If a woman has a breast lump, is biopsied, and it's found to be cancer, they don't say, well, that lump wasn't bothering you. I mean, you were feeling okay. We just found it accidentally on a mammogram, so we're not going to do anything. And you know that that's wrong. But the reason that's wrong is that with aggressive therapy, it's curable. And you can't say the same thing about multiple myeloma. Clearly, the focus is cure. Just this morning, I ran into the husband of a patient who's a 20-year survivor with multiple myeloma. And there are many, and it's increasing rapidly, patients who are 10, 15, and 20-year survivors. But it would be, I think, incorrect to say we can cure this disease. We certainly can't do it with any predictive value. And so the difference between myeloma and breast cancer is, in a breast cancer patient, even if asymptomatic, you can cure it and make it go away, and we're done. But with myeloma, you cannot. So the rationale for the majority of patients is, well, if you have no symptoms at all, nothing, and I can't cure you, then maybe we can just keep a really, really close eye and then intervene when it becomes appropriate, or alternatively, if we can be very certain that multiple myeloma is going to develop in the very near term. Otherwise, for this smoldering myeloma category, where the protein was detected and there were no symptoms, it's okay to watch it, although there are clinical trials ongoing now looking at early intervention to see if that will improve outcomes. So not everybody that has a protein abnormality requires immediate intervention. So I said earlier that the real problem isn't the protein, it's the cells, because it's the cells that damage the bone and the blood, and that the protein isn't really part of the disease, it's just a marker of the disease. And like all doctors, I lied. And so in 15%, actually it's 20% of patients, the protein actually can cause one problem that's unrelated to how many weeds there are. And what happens is that the protein can gel in the kidney. And that's not a function of how many weeds there are or how badly the bone marrow is affected. It's that they have a unique abnormal protein, and this protein somehow, when it gets into the bloodstream and then crosses through the kidney into the urine, plugs up the kidney and causes kidney damage. So actually 22% of patients with multiple myeloma present with some impairment of kidney function, and that impairment of kidney function is related to the protein gelling in the kidney. So those are the three primary manifestations and how your doctor made the diagnosis: anemia, bone disease, and kidney damage. So how do we manage this? And we'll be talking about details, but kind of thinking about it broadly. You've got a garden, garden's got weeds, you need weed killer, period. And the weed killer comes in different brands, different doses. some that are pills, some that's intravenous, some that are shots, that action differently, but they are designed to kill the weeds in the garden. Some are given weekly, some are given daily. Usually you get checked once every 3 to 4 weeks to look at the action of the weed killer. But the thing about weed killer is that it's not really very specific. Sure, it'll kill the weeds, but one of the problems with weed killer is it doesn't just kill the weeds, it can affect the healthy garden plants as well. And that's important because if you were actually treating your garden out back, tomatoes, cucumbers, pumpkins, with weed killer, what you'd normally do is you'd go to the store and they'd sell you the very specific weed killer for those weeds, because the weed killer you use for multiple myeloma is not the weed killer you use for colon cancer or lung cancer or breast cancer. It's all different. That's why there's a specialty. You get the right weed killer, and then you dilute it, maybe a teaspoon in a gallon in a garden spray and spray your garden. And it will kill weeds. But what you won't do is if it says give a teaspoon in a gallon and say, oh, that did a really nice job killing the weeds. So when I go back next time, I'll put a tablespoon in because it'll kill 3 times as many weeds. And of course, the problem with doubling up on the effective weed killer, in this case the chemotherapy you're receiving, is it will continue to kill the weeds, but it can cause sometimes irreparable damage to the healthy garden plants. You don't want that. That needs to be monitored really carefully. Now, how many of you on treatment are getting a blood count once a week? So a fair number. So what's going on? Well, what's going on, of course, is the blood count is actually measuring garden output. Red cells, hemoglobin, white cells, platelets. And they're trying to be sure we're not overdoing it. We're not overdoing it with the weed killer, because if the weed killer is getting a little too high, then you're going to see those normal blood counts go down, and that's a problem because it may predispose you to infection, bruising, bleeding, fatigue. And so the doctors continuously, or the providers continuously adjusting the dose of the weed killer to be sure that the normal healthy garden output is not affected. So there's a real limit to how much weed killer you can give up until 1985. Then in 1985, new techniques were developed, and it became clear that you could go into the garden and get seeds. In 1985, you actually took patients to the operating room, put them under general anesthesia, and under general anesthesia, you took a quart of bone marrow out for seeds. Technology goes on, and it turns out that if you get a shot under the skin every day for 5 days, you can actually get seeds from the garden right into the bloodstream. And then when they're in the bloodstream, you can either stick a needle here and a needle here and take the blood out, take out the seeds and put it back, or you can put a catheter in here with 2 ports, take the blood out, process 11 quarts in 4 hours, extract the seeds, return the blood. And once those seeds are extracted from the bloodstream, so we don't take it anymore from the bone marrow because it's cumbersome to general anesthesia, quart of bone marrow, it's quite a to-do, we take out those seeds and we freeze them. Once the seeds are frozen, seeds frozen are good forever. We've actually thawed seeds out at 15 years. They work as good as new. But in any case, we've got seeds frozen. And now that we have seeds frozen, we're not so worried about garden damage anymore, about doubling up on the amount of weed killer that we're going to cause the blood to be a problem. So what we'll actually do, now that we have seeds frozen, we talked about putting a teaspoon of weed killer in the garden sprayer, but we're not going to put a tablespoon. So what we do is we actually take a cup of weed killer, enough that will irreversibly poison the garden. The garden will be destroyed irrevocably. It'll be completely irreversible. Put the cup, spray the garden, and kill the entire garden. We will kill it. And we'll wait a day or two. And after a day or two, the poison that we've given has left the ground soil. It's out of your body. And then we can take the seeds out of the freezer, and those seeds are now called stem cells, and thaw them. And then we take the seeds from the freezer and put them back in the patient, and we call that. So we're transplanting the seeds back into the garden, and then we will regrow the garden. The problem, of course, is that the garden's been killed and the seeds aren't growing back for about 2 weeks, so you end up with this window that is at best unpleasant, and at worst a lot worse than unpleasant. But that's really the principle in doing that, trying to further deepen the response. And that gets to the question of, what does response mean in this disease? If you've got a breast lump, you cut it out, or if you have a tumor on the lung, you see it shrink, but what's response in this disease? And this has evolved since the 60s, because in the 60s, the only rational way to understand what was going on was to look at the protein level. And it was the protein level that we used to determine response. And in our lingo, if your protein goes down 50%, we cut it in half, however we measure the protein, that we call a partial response, 50%. And if the protein goes down 90%, then we call that a very good partial response, or VGPR. And in the 70s and 80s, that's about as far as you needed to go, because very few people got below 90% of the protein level. But the treatments keep getting better and better, and the outcome and the outlook gets better and better. And now we're seeing patients where the proteins in the blood and in the urine go to zero, and that we call a complete response, a CR, a complete response. Complete response criteria say the proteins are zero. The bone marrow has to have less than 5% weeds in it, less than 5, to be qualified as a complete response. But we always knew in that era that even 5% or 4% or 3%, that wasn't great. That those are probably still, even though there's no protein, they're probably part of the cancer. So the new techniques were developed. One was the addition of the free light chain assay, the kappa lambda free light chain. And then the second were sophisticated ways to measure the plasma cells, the weeds in the garden, in the bone marrow, under the microscope. Because when I started, you looked under the microscope, you counted the cells, and that was the end of it. You counted 500 cells, you saw 9, that's 2%. But more sophisticated, where 10,000 cells can be processed in a minute by a machine. The machine will count the cells for you. And so we moved then from a complete response by adding the criteria that now the light chains have to be normal, and by counting 10,000 cells, we can't find any cells. Now that's a stringent complete response. Finally, and where we are now, is trying to address the question of even more sensitivity, because we think that if we really are going to cure it or produce immense long-term benefit, we need to get deeper yet. And that brings up the concept of MRD, or minimal residual disease. And in minimal residual disease, now we're measuring to 1 cell in a million in the bone marrow. So, and that's eminently doable. It can be done in any lab across the United States. And so then you take a bone marrow, you do 1 million cells, and what you're looking for are 0 plasma cells. And if you are, that would be considered minimal residual disease negative, MRD minus, MRD negative. And if there's residual, it's positive. And so you can have a stringent complete response with MRD negativity and stringent complete response with MRD positivity. And a lot of what the research ongoing now is two things. What does the status of this MRD tell us about how we should be managing our patients with myeloma? If patients still have MRD positive, does that have implications with regard to the way we're treating our patients? And secondly, in patients who are on maintenance, and almost today every myeloma patient is on some form of maintenance treatment, does the MRD tell us about anything about how long the maintenance should be, how long we should be treating patients, and what our end point is for treating patients? So that's kind of the myeloma ABCs as we start actually going into the specific therapies. I should say that you can't forget about the supportive care associated with this disease. Because the bones are affected in 80% of patients, some type of treatment to help improve bone health becomes important. So everyone agrees that calcium and vitamin D is an important supplement to help maintain skeletal integrity. But also there are medicines that are available either by vein or by under the skin injection that also promote bone health by blocking either the remodeling of bone, the cells that actually turn the bone over to allow the bone integrity to improve, or shots that block chemicals that are responsible for mediating the bone loss. So those shouldn't be forgotten. Some of the drugs that we use are toxic to nerves. They damage nerves, and it's a big, big problem. And I'm going to tell you that for preventing nerve damage to the feet from some of the treatments that we have available, to be blunt, the best preventative is having an experienced provider and experienced oncology nurses who actually know the drug, when to stop, when to intervene, because for those types of problems, prevention is the best. It's enough, I think, for this part of it, yeah? We'll be back later to talk about all other stuff and specifics of therapy, but everybody needs to be kind of on the same plane with their basics. Thank you.